This is Anne from WA. Let's make a welcome, everybody.
I'm not sure if any of my WA colleagues are tuned in, but I'm the only one who's able to make it across this week. I job share the refugee liaison nurse role at Perth Children's Hospital in the Refugee Health Service there. And our model in Perth Metro sort of consists of three services. We have the Humanitarian Entrant Health Service, which does the arrival screening for all of the humanitarian migration pathways, and then a community-based refugee nurse program, which falls under the Child and Adolescent Health Service, which also incorporates the Perth Children's Hospital. So we provide the tertiary paediatric service, and we work closely with the community-based nurses who see entire families, even though they come under the Children's Health Service. So our challenges are much the same as everyone has already mentioned today. We're seeing increasing complexity in both medically and socially in our client population. That's obviously flow-on effects into increasing appointment times, number of encounters, and increasing time that clients need to be supported through settlement. With regards to HSPs, we have Red Cross in Perth at the moment, which we're pleased that they have the contract. We've had good relationships with Red Cross in the past. However, as other people have already noted, they are an organisation under a lot of stress, and we have a high turnover with case managers and that kind of thing. So we're always working on trying to improve that relationship, and the nurses at HES have been doing some work around just building a better, stronger connection between the organisations. One of the main issues we're seeing is delay in school enrolment, seeing children several months into settlement. By the time they come to their appointment at Children's Hospital, still have not been enrolled in schools, and that's something we're trying to address. One of the reasons for that has been a delay in permanent housing and a disinclination to enrol children until they have a permanent address, which I can appreciate. Changing enrolment is a whole other layer of difficulty, but if they're in a situation with interrupted education, that delay can actually probably be worse than the time and energy spent in changing schools. Another challenge is our regional families. We have more and more families moving away, and there's no formal regional service in Western Australia. We work with the existing regional health services, often through the population health units, but there's no specialised health service, so we're relying on telehealth appointments, and obviously that can be quite tricky as there's not enough legs on the ground for our patients, particularly they move down towards Albany, the sort of southwest, and that's quite a distance. And our other major ongoing challenge is underserved groups, so those that don't get referred into us through either the formal humanitarian program or picked up by community nurses, school nurses, child health nurses, and referred in that way. There are plenty of others, and we have no idea how many families in need of our support who are not getting engaged. At PCH, our referral criteria is just to have a refugee type background. There's no other real barrier to referral, but we are finding that we'll occasionally pick up families who've come via family reunification pathway, and we're not seeing them some years down the track, and obviously that delay is less than ideal, so we are trying to work on how we might detect these groups, but there's no clear answer to that yet. What's working well, we have very, very dedicated teams across all of the services, and we do have quite a good working relationship between the three, although it is a sort of possibly unnecessarily disparate group. We do meet regularly and try to have a coordinated approach. And one of our major opportunities at the moment is that with the amalgamation of the Child and Adolescent Health Service, the community and tertiary mental health services are now sort of unifying under one service. With that is the opportunity to integrate the Refugee Health Service. So we're looking now in the process of looking at a new model for the PCH and the community-based nurses to essentially be one team and probably have one referral pathway, and we can increase some efficiencies and hopefully provide a better service that way. So hopefully we'll be able to report on how that went next year. That's about it.
Thank you, Ta.